Today I'm going to talk about Ebola virus disease. Some of you may have been to my earlier lecture in August where I talked about the disease and a lot of the scientific data behind it. That data, I'm not going to repeat that talk today. Those slides are on the EJMD portal, and you can reach those through Team Talk. Today I'm going to do a few things. I'm going to discuss the outbreak a little bit. We're going to watch a short video from Dr. Bruce Ribner at Emory, who will lay out some of the clinical findings that they discovered during their care of Dr. Brantley. We're going to review the CDC criteria for a very important distinction of patient under investigation for Ebola virus disease. We're going to review an action plan for that patient under investigation, and then we're going to have a personal protective equipment demonstration from Lane Estrada and Scott. So first I'm going to show this video, which is going to go over some of the clinical findings that they had from the patient at Emory. And I hope you find this as helpful as I did.
I'm Dr. Bruce Ribner. I'm the Medical Director of the Serious Communicable Diseases Unit at Emory University Hospital in Atlanta, Georgia. I am one of the speakers at the plenary session this afternoon at the ID Week Symposium, and my topic will be Ebola virus in the United States, lessons learned. So what have we learned by treating patients in the United States with Ebola virus disease? Firstly, and perhaps most importantly, we've learned that we can do it safely. We always thought it would be a safe activity for our unit, but it was gratifying to see that we were able to accomplish this without any secondary transmission of infection or even any possible secondary risk of transmission to our healthcare workers. This was very important for public perception. Number two, we have infrastructure that is not available in West Africa. We were able to make a number of observations which they had partially guessed at, but really weren't able to make because of their lack of infrastructure. We learned that the metabolic abnormalities are much worse than they had anticipated. Potassium levels, sodium levels, calcium levels, magnesium levels were markedly abnormal in all of our patients who came to us with Ebola virus disease. We also learned that there is an enormous amount of third spacing in these patients. All of our patients gained approximately 10 to 20 kilograms, primarily in their third space. They gained this because they were profoundly hypoalbuminemic and they had substantial endothelial cell damage. Paradoxically, they also were hypovolemic, again, because of hypoalbuminemia, hypoproteinemia, and the endothelial cell damage. Our colleagues in West Africa had kind of thought this was going to be the case, but frequently don't have any testing equipment to measure that. The other thing we appreciated was that these patients have an enormous output in body fluids. Again, our colleagues in West Africa have observed that this was the case, but when we fed back to them that we were measuring 5 to 10 liters of output a day, even they were somewhat surprised. As I've mentioned, we have fed this information back to our colleagues, and they have already begun to make some management changes, increasing the amount of potassium, calcium, and magnesium that they are giving the patients, and also, again, being aware of how hypovolemic these patients are. The other thing we've begun to look at is experimental agents, but again, we emphasize that the role of these agents is totally unknown. Safety data in humans for most of these agents is non-existent to negligible. And it is really aggressive, intensive care that we feel has made the difference in our patients. We've also demonstrated that you can have patients who are ill enough that they require being on ventilators, being on dialysis, and receiving multiple other modes of supportive care, and yet they can make pretty much a complete recovery if we are able to get them over the acute episode. In terms of viral shedding, we have substantiated a lot of the data which has been sort of available piecemeal from the African outbreaks. We have found that the virus is present on the skin surface of patients when they're acutely ill, in their vomitus, in their feces, in their blood, in their urine, in the semen of males, and in just about every fluid we've looked at. And this clearly helps us to understand why these patients are so contagious. In the one patient we looked at it in the dialysate, when they were on dialysis, we did not find it. And somewhat reassuring is, in fact, that when we did multiple samples in the room, looking at the toilet, the various surfaces in the bathroom, as well as high-touch surfaces in the patient environment, we found no evidence of virus. Once again, substantiating that our standard infection control techniques are perfectly adequate to create a safe environment in which to take care of these critically ill patients. We were very saddened today to learn that the patient who was found to have the Ebola virus disease in Dallas succumbed to that infection. We had no illusions that every patient who we treated with Ebola virus disease would survive. We thought our outcomes would be substantially better than the outcomes that our colleagues in Africa are seeing at the moment. But these are critically ill patients. They have multi-organ failure. We should anticipate that there will be some fatalities associated with this infectious disease.
So I think some of the important takeaway points from that review were 5 to 10 liters of output per day, so massive amounts of fluid shifts, hypovolemia, lots of electrolyte disorders, very critically ill patients. And then the last thing I thought was very important was that the viral shedding didn't show any environmental surfaces were able to have virus found on the surfaces before decontamination. So even though there are large amounts of viruses on the skin and in the body fluids, there isn't a large amount in the environment. It's not a very hardy virus that stays on environmental surfaces for a very long period of time. So to review what's going on with the current outbreak, I would like to say that there are actually 2 outbreaks of Ebola virus at this point. One, if you want to include the American experience, that's 3. But there is an outbreak in West Africa, which involves the 3 countries that we currently know are affected: Sierra Leone, Guinea, and Liberia. And then there's a second outbreak of a different strain, which is much, much smaller, only 38 patients confirmed, in the Democratic Republic of the Congo. It's a different virus, it's related but different, and there are a lot fewer cases, and there's no evidence of transmission between the 2 areas that has occurred. And it's in a very remote area, which typically Ebola virus outbreaks have been in the past. So to date, there have been approximately 9,000 cases and 4,500 deaths. A review of the timeline, there have been a number of different outbreaks, and one of the reasons I'm going through this is to show you that they've been contained. Some of these patients you may not even be aware of. You may remember that in July 20th, there was a patient who came to Nigeria from, I think, Liberia. He was detained at the hospital. He infected 20 other people, including his physician, who later died. Only 8 people died, but 42 days later, the country of Nigeria is still Ebola-free, and was declared so yesterday. On August 29th, a student crossed over the closed border between Guinea and Senegal just walked. He was eventually located in the city of Dakar. He survived. No other cases occurred. No transmission occurred. Senegal was declared Ebola free on October 17th. You can't see it because of the and 800. You can see there was a massive contact tracing taken underway in Nigeria, but no other cases occurred. The American experience on September 15th, Thomas Eric Duncan, I think everybody knows some of this story, was exposed to a woman that his neighbor who was pregnant, helping her to get some help. She died the next day. He took the plane, arrived here on the 20th, passed through checkpoints with normal temperature. On the 25th, he presented to Dallas Presbyterian with fever and abdominal pain. There's some reports that he was vomiting at the time. From what we understand now, he told everyone that he was from Africa. It's not clear whether he said he was from Liberia or not, but he was sent home with antibiotics. On the 28th, he was admitted, but it took 2 days for them to declare that he had Ebola virus disease. He died on October 8th, and then 5 days later, the first nurse was diagnosed with Ebola virus disease. She has been transported to NIH. And on October 15th, the second nurse was diagnosed and she was transported to Emory. And they're both doing well so far, as the last report. So far there have been no outbreaks, and all the family members that were living with Thomas Eric Duncan while he was sick have been released after they've finished their initial incubation period. Some of the experience in Europe that you may not be aware of: on August 7th, a 75-year-old priest was diagnosed with Ebola virus disease from Liberia. He was repatriated back to Spain. He was treated with ZMapp, which is a monoclonal antibody I discussed in my first lecture, but he died on August 12th. On September 22nd, another priest from the same order was repatriated from Sierra Leone, and he died on September 3 days later. He was not treated with experimental agents. On October 6th, a nurse's aide who took care of both of these patients was declared infected. She was treated supportively. She survived. PCR testing on her blood shows that she's Ebola virus free, and she was declared Ebola virus free yesterday. 72 people are still under observation, but no new cases have been reported. On October 7th, a physician working, a Norwegian physician from Médecins Sans Frontières, Doctors Without Borders, was diagnosed with Ebola virus disease. She was repatriated to Norway from Sierra Leone. She was treated with experimental agents and also declared Ebola virus free. No new cases occurred. The virus was controlled. So you can see there were actually a number of cases of patients who presented to Western hospitals who were appropriately treated, survived, and the infection was contained. We don't know what the Norwegian doctor was treated with. So the CDC has come out with new criteria to determine if a patient is under investigation for Ebola virus disease. And this is important, and you really want to make sure you use the proper language. Suspecting someone has Ebola virus disease is just that you think they might have Ebola virus disease. But you need to use a combination of epidemiologic and clinical criteria to see if they are under investigation for Ebola virus disease. So you need a detailed travel and exposure history. You want to know that the patient traveled to an Ebola-affected area within the last 21 days. And right now, that's pretty much the three countries in West Africa. All the contacts that we have in the United States are actually known, and they're being traced and followed right now. There are no new cases so far. So you have to have an exposure to a known or suspected case within the past 3 weeks. You also, in addition to this exposure history and travel history, you have to have fever and you have to have other symptoms. So you can have two of these And I think you could say that that person is a suspected case, but they only become under investigation when the Department of Public Health gets involved, and there are blood tests pending. And so what we want to do is make sure we use all of those. Now, here's the countries involved: Guinea, Sierra Leone, Liberia. Nigeria is way over here. Senegal is up here. So an action plan that we've come up with, and one thing I'll just mention is that we're going to have a town hall, I think tomorrow, three times tomorrow. And we're also going to have all these things on the EJ website, so you can review that if you need to. But we would recommend that you screen patients before going to your clinic or the emergency room. If you have a well patient, you can simply ask a travel history and just say if you've been anywhere in the last 3 weeks. If you have a sick patient, you should ask them if they have the symptoms that I described: fever and nausea, vomiting, abdominal pain, muscle aches. And keep in mind, if they don't have a travel history, they may just have the flu. If they do have a travel or exposure history, then what we would suggest is that you tell them to stay home. If the patient does, however, show up in your facility, isolate the suspected patient either at home or in a separate room with a private bathroom. And of course, that's because they may have body fluids that they have to get rid of, and they need a place to put them. At this time, we're not recommending that you let them flush the toilet if they do use the bathroom until we know what their status is. There are two versions right now. You can contact EMS and they will discuss things with DHH, or you can contact DHH directly. What we'd recommend that you do, and what we've discussed with EJEMS, is that you contact them. They will come dressed out and they will have the discussion with the Department of Public Health to decide if that patient is under investigation or just a suspect patient. Hopefully what that would mean is that basically that you close the door, you call EMS, they come and see the patient, they'll talk about it, and then they'll take care of transporting the patient out of your facility. There are no plans at this point, to my knowledge, of transporting patients to other hospitals, but this hasn't come up yet. There are 11 biocontainment beds available in the country, and 2 of them are already taken at NIH and Emory. That leaves 9 left. So obviously that would work if we have smaller little embers of an outbreak coming up for people who are traveling, returning travelers who've become infected. Only if labs are performed is the patient called a patient under investigation, and then only if they're confirmed to have Ebola virus disease are they considered a confirmed case. Then the CDC calls the state health officer, the Department of Health and Human Services, the Homeland Security, state police, everybody, and begins all the contact tracing and the things that they are supposed to do. So one of the things to remember is that other things can cause fever in returning travelers, including hemorrhagic fevers that don't include Ebola, malaria, typhoid fever. This is from my previous talk. Other viral hemorrhagic fevers such as yellow fever, Lassa fever, dengue. So you don't necessarily have to think about Ebola, but definitely we want you to. And the new CDC guidelines, Lane and Scott are going to give us a demonstration in just a minute, but I wanted to go over some key points so that you recognize what is a little different. Rigorous and repeated training. We're going to try to have a small number of people who are rigorously trained in this so that they can do it over and over again, and they can also be the monitors to watch the other people do it and help them. No skin exposure and no mucous membrane exposure, obviously. Previous reports had some people with some skin exposure with their equipment. trained supervisor and buddy system watching all workers taking the personal protective equipment on and off. So we're going to have both a buddy and a supervisor at every place to watch people do this if we're taking care of a patient. Limit the personnel and have an on-site Ebola site manager. I don't know if we've designated anybody yet. Me, that just got it. So, the new items, double gloving, we were planning to do that anyway, but an impermeable gown, boot covers, respirator masks, these are N95 respirator masks, face shields, surgical hoods, apron or gown for other body fluids that might be splattered. Designated areas for changing, clear separation of clean and contaminated areas. This was a problem with the Dallas experience. Disinfection of personal protective equipment before removal, and disinfection of gloves between each step of removal. And those are the two steps that I think consistently we find that are the most important. You're spraying bleach on the person before they take off the personal protective equipment. That's the buddy who's obviously dressed out, as well as washing the gloves in a bleach solution between each step of taking each item off, so that there's no question of cross-contamination between steps. With that, just remember that there are 3 town halls tomorrow where we'll discuss policy. There's everything on the website as well. And I'll leave it open to Lane and Scott to show you some equipment.
Good afternoon. My name is Lane Mistretta. I am the educator for the ED and Oncology in the Education Department, and Scott Hunter, Director of Critical Care. It has been an evolution over the past 4 weeks, 3 weeks when we started our ER staff meetings. We started donning just the outer protective gear, and we have evolved with CDC's recommendations. And as of the last week, we've exceeded the recommendations of CDC, and still today we're at that a couple steps ahead of what the recommendations are, providing extra protection for our staff, both physically and mentally, as far as for wanting them to volunteer to get into the area of contamination and address and take care of the patients with ED. So this is the end product that we had 3 days ago, and with the exception of the N95 that has been replaced with the regular surgical mask that was in place 2 days ago with the recommendations, as well as the hood that is on order. It's on back order across the country. We were supposed to get those in yesterday. As of yesterday afternoon, they were not in yet, and this morning we checked again, they were not in yet. So the demonstration we're going to do is the one we've been doing for the past 2 days, but the hood may replace the outer, the hood from the Tyvek suit that we're going to demonstrate right now. First things first, we want to have somebody healthy going into the room to care for the patient. It is a strenuous exercise at best getting in there, and it's very physically demanding to get into the PPE that we have set up. Scott demonstrated it during our trial and error period and talking through each step. He was able to stay about an hour and a half in our Thai Chem suit, which is the yellow, more plastic type of suit. And when he got out of the suit, he was drenched from head to toe and exhausted. So we want to limit that type. And what they're saying in other facilities, we may not have available to us today. So we can't keep the nurses in the room at the bedside 2 to 3 hours at a time and then rotate out. They're in with full hoods and pappers and ventilated headpieces and air conditioning and things like that. We don't have that here. So we're going to use what we have and provide the ultimate protection for our staff. So first things, we want him to change out of his outer garments, put on our hospital disposable scrubs, use the restroom, hydrate well with a non-caffeinated beverage such as Gatorade 10K, because he's going to be in there and lose copious amounts of fluid. So he's going to do that, come back, and we're going to start off with the first thing. Because we do not have the hood, the exposed piece everyone was complaining about was the neck area. So to cover that, and we've done it over the past week and it's worked well, We're putting actually a surgical mask straight over the neck. And we're going to tie it up to keep it up and high and into the back. So that's going to put that on. Each person, as Dr. Ehrensing stated, is going to have a buddy as well as a monitor. We didn't develop the checklist because, as you see, the processes evolve. So we're going to have step one, neck, tie the mask around your neck, and it's going to be check, done. So each time somebody gets in and each time somebody gets out, we're going to make sure that each step is adhered to. We're going to be using nitrile gloves for the first 2 layers. They're the long cuff nitrile gloves, so they're going to come up beyond the regular wrist area to provide extra protection. CDC recommends 2. We're actually using a 3rd pair. The 3rd pair, 3 pairs, and the 3rd one is going to be the working set that's constantly becoming on and off. You're going to wash them as you use them and replace and wash underneath and put a new pair on top as you're working with them. So those are on. We're going to use the N95. This N95 mask has come into critique. We're ordering some new types and models of N95, much softer in the middle. It's causing some nose damage over longer periods of use. Put some pressure points on it. So what we have now is what we're going to use. It's still N95. We may use a different version. The hospital has purchased some non-porous shoes to assist us in containing and preventing exposure. Any hunters out there, volunteer, we can go ahead and put these on. These are Crocs. If Scott would have wore his leather shoes, we could use those as well. We're going to double cover no matter what we wear. So we're going to put these on. Keep those on. There's a chair in the front here. Sit down right here. And we're going to double shoe cover whatever footwear that he's wearing, either his own or the Crocs.
Let me just say too, at this point, a lot of physicians are not going to be seeing the patient that if we end up taking care of one. We're going to have consultations by phone, maybe video, but we're going to limit the number of people going in and out of that room as much as possible. So there should be very few people actually doing this at any given time while we rotate in and out of the room.
During the process, if I identify any breach at any point in time, I'm going to stop, redo. He just split his shoe cover, use supplies. We're going to continue with this in this scenario, but I would actually have him remove that and put a fresh pair on. So the Tyvek suit, much more breathable material than the Tyvek suit. The yellow one is more classic. It's like putting a tarp on. It comes in multiple sizes, from medium to triple and 4XL, so we can fit accordingly to the provider. We want to prepare the Tyvek suit. It comes with no thumb holds to hold onto. So if I stretch out, especially some taller people, Dr. Ehrensing put it on, he did this, and the Tyvek came up to here, and the gloves were over here. So we want to put the thumb holes and use appropriately sized suits as well. So Scott is going to use an extra large, and you're going to be able to see it's still somewhat snug for him. So he may need actually a double X or a triple X for his height.
And that was recommended not by the CDC, but by a physician who actually works with Ebola patients in Sierra Leone. So it actually has some experience behind it.
The buddy should be helping him out as much as possible, keeping him cool. As the more work he's doing just to try to put pieces and parts on, he'll start sweating to begin with, and he'll provide less time in the room. The boot covers are going to be next. We want to provide coverage for the outer garment, even though his shoes are covered already. When he steps out of the hot zone, he's going to be doffed without all of this PPE. The outer gown, the shoe covers are going to stay in the hot zone. He's going to step out just with the Tyvek, and I'll go ahead and disinfect the Tyvek suit, not the hot stuff that's in the ground. So we want to add protection to his feet. Easiest way to put these on is roll them down and then roll them back up. It takes about 20 to 30 minutes, about 20 minutes with narration the first time to get in and out, about 10-15 minutes each way. So you have to allot yourself time, especially if you're in the environment. If you want to get out, you can't just run away, run out. Panic attacks, you need to give yourself some ample time to doff all of the gear safely for you and the team that you're working with. Initially, when you put the equipment on, if your individual has not been trained or has practiced enough, when they're putting this N95 mask on and then they put the hood on, that face shield is like closing the coffin. It is extremely claustrophobic for some people. It's closing them in, and it's Scott didn't have a good experience his first time, so just saying. We want to put the second set of nitrile gloves on, and I'm going to now take these gloves. Sorry, nobody. Oh, Scott, just put the gown first. That's why we have a checklist. Put the gown on. It's a regular level 3 gown. And I'm making sure that everything is covered. And now we can put it again. We can use good old duct tape to secure the gloves to the outer layer. We can use chem tape, but it's $30 more a roll. It does the same thing, non-porous tape as well. Tab the end for easy removal. This is going to be removed prior to leaving the hot zone as well. So, face shield on. The face shields we currently have, we have several limited supplies. I didn't want to use all of those for training, but they do come down another 4 to 6 inches longer. When we have the hoods that are coming in, it's going to cover the neck. So it's going to be easier to use that face shield. These are a little bit shorter. Different types of connections on the back. We want to make sure that it goes low enough on the posterior surface of the head down here, so it's not going to ride up, and if I bend down, it's not going to pop off. So it's one of the things that the buddy's watching the whole time you're in the hot zone, that if something does come off or if you breach, you must remove yourself from that environment. And that's in the call of yourself or the buddy. One way also to prevent fogging is that we wipe the inside of the mask with some alcohol to prevent it from fogging up. We'll notice that it'll start fogging a good bit. We have some spray they're looking into getting as well, like the surgical instruments. RainX has one, I think. And then the last thing we put on before we go in is the third set of gloves, simple short cuff nitrile gloves. And these will be the working pair that I'm going to constantly remove, wash, and then reapply while I'm in the hot zone. A little warm.
Okay.
I've mapped out on the floor kind of a mock-up of the ER room 6 and of room 22 upstairs in ICU. There's a huge floor plan and projection for when we do have a patient. It may take a minute to get set up, but our building services team is going to erect this perimeter outside. ICU is going to be cordoned off from the entrance on the TO unit all the way through room 25. ED is going to be cordoned off from exam 1 when you walk into the main ED entrance doors all the way to exam 6. That whole area is going to be more of an anti-room warm zone so we can decontaminate and get our staff straight. Multiple supplies are being used. And come right this way, Scott. Garbage bags all over to keep trash containers. Walking into the ante-room, the door is going to open. He's going to come in and take care of his patient. I will be, as a buddy, the exact same donning as the person who's taking care of the primary care of the patient. I have to be ready to go in and get him, to take over, to assist. So I have to have the full PPE as well. I have a third person behind me making sure that while they're in there, I've doffed and donned the PPEs appropriately with their checklist. So there's always several people in the process. If the person is critical enough to where there's 2 of us, then number 3 better be dressed out, ready to take us out of gear. They have to be fully done in the same PPE that I do. We have the gel, a lot of liquids, a lot of bodily fluids, bedpans, urinals. We have bedside commodes. If the person's a walkie-talkie, can move around, they can actually get up and go to the bedside commode with red bags. We have this powdered gel stuff that turns all liquids to solid. We'll be disposing of solid waste versus liquid waste. That will be stored, red bags, containers, and then transported on nights, after hours, to a disclosed area. All right. So if Scott gets his hands dirty during the event, he needs to then remove his gloves, not to splash or fling them across the room. Into the red bag, we're going to separate clean from dirty, even into the dirty hot zone. Wash his hands and don a new set of gloves. Let's say he's ready to come out. He's finishing up his last task, just for time purposes. He's going to wash his gloves, including the tape. He's going to then remove the tape. It's the door. He's going to wash his hands after he's done that task. In between every step, they need to wash the hands, even of the gloves. Wash their gloves, actually. Before the person can actually get sprayed down, an area has to be set up. A confined area such as an ante-room in critical care, which will probably be set up by the time the patient gets up there. In the ED setting, the person's going to be in the room. I'll have staff in and out by the time they get it set up. So, as a fair compromise, as well as recommendations from the CDC, the wipe down with bleach wipes is just as effective as the spray. So he's going to turn around. I'm going to assist him in doffing his PPEs. Hot PPEs are going to stay in the hot zone. So we want to contain that area. If he has any obvious large soiling to his clothes, or I can use the bleach wipes with those, and then keep that in the hot zone as well. Otherwise, I would assist him to dock his PPE. I would untie.
Keep in mind, Lane's
In,
wearing
remember-
PPE too.
What's that?
You're fully,
Yeah, I'm fully donned just like he is, but haven't been contaminated yet. So I'm rolling everything down, trying to keep all of the contaminated waste, or contaminated here, inside itself. I'm going to go down as far as his elbow so then he can flex and then take care of it himself. On the inside, he's going to take his inside hand and come over and take off that first set of gloves with that PPE. Leaning forward, not to contaminate his tie-back suit. He's going to hold everything out and then roll it slowly. And then discard the whole thing as one unit in the salt supply. What do you think he's going to do next?
Wash his hands.
Definitely wash hands. As the person on the outside, I'm going to be the buddy. I'm going to help him get rid of his shoe covers, his boot covers, because I don't want him going back down and try to bend over and balance or anything. So I'm going to be on the outside. On the end, I'm going to roll them down just how I rolled them up, keeping the outer part of it on the inside. Hands are clean and dirty. Dirty. What I'm going to do, remove my outer set of working gloves. I'm going to wash my hands. I'm going to don a new set of working gloves so that I can prepare for him, okay? I'm still non-contaminated. I'm not going to eat lunch with my suit on, but I'm not going to check. He's going to step out of the hot zone into the warm zone onto bleach-soaked pad or bleach wipes, so he can actually step onto the bleach wipes. At this point, say we're in the ED and I don't have my spraying set up, my spraying capability set up at this point in time. I'm going to take the bleach wipes and I'm going to wipe him down from head to toe, his entire body with bleach wipes. Okay? He is now disinfected. Again, I'm going to wash my hands. If he were in the ICU setting, in the full setting, or later on in the stay in the ED, we now have a grid, kind of like a built-in grid with a drain underneath it. He's going to stand up over here. In the ante room. He's going to walk to the grid, which is right within that still warm zone. And I'm going to get my trusty garden sprayer with a 10% solution. And just beat him up. I'm going to spray him down from shoulders down. Not anywhere near the face or the neck. So I'm going to spray him down, and he's going to stand kind of in that position, slowly going through. It's going to catch all the waste and be sumped out to a drainage container. Let him sit, drip dry, and then step out onto another pad or towels or whatever. Anything we use is going to be thrown away. Laundry will not launder any of our supplies, so you can step onto another drainage pad. Make sure my hands are clean, and I want to start taking this piece off of him. The problem we have now, or the concern we have now, is once I remove that shield, his eyes are exposed with this membrane, right? So I have to be very careful removing this piece. If this piece got soiled in any way, I would wipe this down with the bleach wipes as well to make sure that there's no obvious problems with the mask. So he has clean hands. He's just been washed down with bleach, so I would prefer him do his own mask. He can lift it up from the sides, up and out, leaning forward and drop it in a receptacle, versus me trying to pop it off his head some kind of way. So I can assist him if it's Velcroed or tied. But if he wants to close his eyes at this time of removal. Okay. And now I want to start removing his Tyvek suit. The most important thing here is to be careful of the eyes since it's going to be exposed at this time. So I want to take him and basically roll back and fold up. I'm sorry?
He washes his hands.
Sure. Thanks for that. That's the monitor doing a check mark. He can wash his hands, which is the handless sanitizer from the front lobby. We're going to roll this back, and again, as I'm removing, I'm trying to make sure that this is constantly rolling down the dirty stuff on the inside. Unzip. Get it past his shoulders, and I want to make sure that the gloves come off as well. As you see, if you have to get out quickly, it's going to take you a good 10, 12 minutes with narration to get out. But you want your most OCD buddy doing this with you, okay? The shoe covers are coming off with the Tyvek, and he's left with the non-porous shoes. Wash, new gloves, he's washing, new gloves, and then he's going to remove his face mask. In order to remove the N95, you want to hold it firmly against your nose and your face, undo one elastic strap, the other elastic strap, forward, and pinch. Wash your hands again. I can help him. I have washed clean hands, and he can do the same, or I have gloves on, I would do so, and help him remove this. There is a kick basin, confiscated from dietary with bleach solution here. He can kick his shoes into that on his way out of the warm zone into the shower area. I would then be prepared to go into the hot zone if I needed to, and then someone else would be coming behind me to be my buddy in the hot zone. Any questions? Yes.
You're not going into the hot zone properly. Who's helping you on that?
There's someone dressed out, ready to prepare to help me out. And yeah, it's kind of a cycle, but the person who's not hot can then start donning themselves with least amount of PPE.
Do you need to wash your hands with bleach each time?
Bleach solution or alcohol-based stuff. Like he said, it's not a strong standing virus. It's sensitive to most soap and water product type of stuff. So the alcohol-based solution is sufficient. And we have the handless, you don't have to pump it. It's just the automatic dispensing, so you're not touching any surface. In the area itself, when they're in this room, before they would leave, they're wrapping the garbage, they're doing their stuff, cleaning the surfaces before they actually step out. So this area would actually be cleaned and ready for the next user. Unless you didn't like it. Any other questions?
You said it's like a cycle. How does the cycle end? Who will that person in? Who's going to take something off?
Someone's always have to be dressed out, donned, ready to go into the patient's room. It's unlike we can sit at the nurse's station now and just, oh, call bell, let me go run in and check. They may have a call bell that's going to take 15 to 20 minutes to get into that room. So someone's always going to be donned, maybe not in the full PAPR and ready to go in the full N95, but just ready to go at a moment's notice with least amount of preparation. Yes?
In the emergencies, or perhaps in our clinic, if someone shows up and says, "I need to get us down to a fever," the person who brings them inside has to dress like that?
You're not. He wants to know if the person who's actually bringing them to the room 6, maybe from triage or from whatever.
I think the question was if you have someone in clinic.
Yeah, for us it's going to be in clinic. But
Right.
I think somebody, analogous, somebody walks into the emergency, but someone comes into the family practice clinic. We're just wondering how that person would handle that when they say they're at the front desk saying, I have a fever that I just heard was.
Well, basically what I would recommend is the physician or clinician provider walks out of the room, washes their hands, and closes it and said, we'll get EMS to come in and talk to you. And close the door, call EMS, call the Department of Public Health. It should be that simple. Then if there's a question of whether or not you should worry about the environment, I think you'd have to handle that after EMS took the patient away. If they took the patient away, because they're going to do a phone call to the Department of Public Health, and they're going to talk to an epidemiologist with the patient, and they're going to make a decision whether or not that's a patient under investigation or not. And if they're not, then they're not. You may not want to go back in that room, but they're not. And then, but if they're under investigation, they'll be taken away by EMS to a facility, whatever that determines, whatever that is. So my advice would be just to say, okay, it'll be, someone will be with you shortly. Yes.
You talk about just people that travel to Africa. So.
Or have contact with a known or suspected case,
right.
All of which we're
following.
following.
I guess today, later on around this afternoon, there's supposed to be a patient coming into my clinic that worried that he might have been exposed. But all it is he just went to a football game in Dallas.
Mm-hmm.
So now he said he has all these symptoms. So
he's not a suspected case.
It shouldn't be because, right? Just
unless
because
you
he
can
traveled
tell
to
me.
Dallas doesn't mean he is positive for it.
Well, a lot of people have been to Dallas. So,
right.
I mean, if he can say that he has a name of someone who's sick, that he's been in contact with, that's important. That person had to be sick for him to be an exposure. Or he's traveled to some place where people were sick. And he's not
He should not be a candidate.
No, he has something else. He probably has the flu.
Right.
Eric, how should we handle if they've been in the waiting room for a while waiting and then they come in and they're taken to a treatment room and they're going to EMS? How do you handle the people that are in the waiting room?
Very careful.
That means you just, until you get an okay from EMS.
I think you'd have to talk to the CDC and they become low exposure risk for contact tracing. I don't think that they would be at high risk because hopefully that patient wouldn't be very symptomatic and the patient may not even be that symptomatic at all. But I think they'd have to have a discussion with the CDC and they'd probably follow for a while. It'd be bad luck. That's why we're telling people to call patients that if you're calling to confirm appointments, just ask them if they've gone out of the country for the last 3 weeks. If they've been out of the country, the next question is where have you been? And if they're coming in to see you because they're having a fever, ask them again. Have you been to any place out of the country? Have you been to West Africa? I think everybody at this point would understand why the questions are being asked, and then tell that person to stay home. So hopefully, we won't be getting too many of those surprises.
Did you just say West Africa?
I did say West Africa.
No, I said that's all you have to ask me. Just have you been out of the country? Do you have a fever? Have you been in?
I think if you got to the point where in West Africa, they should know because they took the plane there. But you could ask them that question.
I don't care where in West Africa. They say West Africa.
Well, I'm just saying exactly. If you say West Africa and they say yes, you're going to say goodbye. No, you're going to say. But I think everybody would understand where you're going with that, unless they live under a rock. Any other questions?
Given the rigors of the donning and doffing of all this equipment, are all these patients going to be no codes?
That's a question we have to ask when we get there. There's a whole bunch of ethical issues we have to ask. I don't think so, but we have to ask that question. That's going to be an ethics question that we're going to discuss when we get there.
I want to remind everybody that there's 3,000 people in South Louisiana that are working off the west coast of Africa. So I think we are a little bit more at risk for potential exposure than a lot of other states.
And we're also a port city.
Yeah.
So we have lots of people coming in and out that could be either working or traveling from or to West Africa. I think there have been some laws put in place today, or some executive orders from Governor Jindal that we're going to know some of those people and who they are and where they're going within the last 3 weeks of their travel. But they're very simple questions. You can ask them. They're just like, when you get on a plane, have you been to West Africa? They're easy questions to ask. Yes.
So, the people who are making the appointments or answering the phone, do you recommend that they be trained on those 2 questions to ask before the patients walk in the door?
That's what I said. Yeah.
Okay.
Yep.
No, but they're not here, and I just want to make sure I talk to our clinical director about that.
That's going to be, actually, that's coming out shortly, or it should be out already.
Yeah, are you aware of anything? I've tried to look. We know the mortality on this is somewhere between 50 to 70%. Any data out there that you can find, again, getting back to your question, this guy in Dallas, they intubated him, they dialyzed him, okay? Anything about sort of the futility of care, in other words, if you develop the point of developing respiratory failure, if you now have a 99% mortality, then it's futile care to even intubate these people. If you develop renal failure and your mortality is the same, it's futile care to do those invasive things. Is there any data out there that you're aware of?
No, because most of the time, we have a number, I can count on my hands how many people are in Western countries when they contract Ebola, because I just reviewed it. Only 1 or maybe 2 of those people received dialysis, and 1 survived and 1 didn't, as far as I can tell. So I think that's a 50-50 chance right there. So again, I don't think there are any data that say you're more likely to die if you reach X point, and then it becomes futile to do anything beyond that point. There are just too many. There are just too many unknowns about that, because nobody's had this, and I hope we don't find out that we don't have the numbers to say that's a futile case. I would say from what I've read and from what I've heard and from what I've talked to people about, that at a certain point you have such severe endothelial damage. we're talking 5 to 10 liters of fluid per day, of body fluid that's being expressed. That it's a monumental effort to try to replace those, and certainly could be futile. When you destroy a lot of endothelial damage and you have a lot of bleeding and a lot of fluid loss, I can imagine that it would be futile at a point, but I don't think there are any data. There's not enough numbers. Thanks for coming.